from Penn State Hershey, and I'll let him introduce his panel. We'll get a clicker here if you need it.
Okay, well, thank you for the invite. It's really always nice to be here, particularly this time of year. I've listed the distinguished panel alphabetically, not necessarily, well, actually probably by wisdom and experience as well, but actually I listed it alphabetically. Okay, I want to be clear about that. That's the only way I listed this. Just kidding. So we're going to get started, and I'd really like to make this as interactive as possible. So if you have a question, the room isn't that big. Raise your hand and try to ask it in real time. I can see everybody. We'll try to get to it. Okay. So, Bill, this is your case that you sent me. I don't have an age on this patient, but this patient had a car that crashed into a concrete wall, brakes failed, and went down an incline, had a head injury, had a right lower extremity injury. This looks like it was in the trauma bay, and had a segmental open fracture of the tibia, an open fracture dislocation of the talus, a Hawkins 3, and looks like it's in splints at this point. And the question at this point is treatment, priority, timing. These are the questions you proposed. Why don't we hit the other panelists first? So Susan, you have a segmental open fracture of the tibia. You've got a Hawkins 3 fracture dislocation of the talus, which I can't, that might be open as well, looking at that picture, but yes. I'm not sure. Yeah, open as well? Okay. So what are your thoughts about sequence, timing? Susan, what do you want to, can you see this okay?
Yeah, the seats are a little low. We're all struggling with that.
Oh. Sorry about that.
That's okay, no worries. Okay, so while I was fuddling with my seat, I wasn't sure, did you say that are they like, everything we talked about at the last session, are they okay hemodynamically?
Why don't you assume yes? Bill, is that a true safe statement?
Okay.
Patient stable?
Patient stable, yes.
And the only thing I'd like to mention about that to the audience, because there's a lot of residents here and stuff like that, is I try to teach my residents, you got to be super, super careful about just coming to your attending and say, guy's cleared for surgery. Boom. Just because someone said they're cleared for surgery. You need to know what that means. And, as an attending, I'm always asking my guys, well, what did the echo show? And they, 50% of the time, they don't know. So it's your obligation as the surgeon to be the captain of the ship. You cannot say, well, anesthesia said it was okay, and the guy died, so it's their fault, You have to be intimately involved in all these decisions about who is stable and why are they stable. And it doesn't mean you can't use other people's expertise, because you're not expected to know as much about their heart as the cardiologist. But you have to have very cognizant, careful conversations with these people, certainly as the attending, and I encourage the residents to learn to do the same thing, because these are serious decisions. So the first thing is to make sure that this guy's in that go mode, and if we've decided we're going to go ahead, then you have to treat the emergent parts of his injuries. So obviously he has open fractures. They need surgical debridement, excisional debridement, and irrigation. They should call it a D&I, not an IND, because you need to focus on that really aggressive debridement. And he needs provisional stabilization, most likely, because I tend to be a don't try to get too much done on the first night kind of gal, because I've had a lot of experience over the years with people who kind of poop out on you in the middle of your operation. And so unless there's something that demands immediate definitive care, if it's polytrauma like this, I would lean towards being a little more conservative and getting the priorities addressed first.
So Susan, what scares you about this patient? What do you worry about? I mean, what is, when you look at this, given all the years of experience, what do you think is going to be the big problem here down the road for this patient?
How old was the guy?
I don't
Young?
know. Bill,
Young?
The guy is 58 years old.
58, that's a big problem, right there.
Wait, being
No.
58 is a big problem?
Seriously.
Oh
for
boy,
trauma
I got a
it
big
is.
problem then.
Anything over 30, as we know, is like a big problem when it comes to trauma. They don't respond as well.
That's so depressing.
Everybody on this side of this audience is like in big trouble if I get into an accident like that compared to an 18-year-old. And you have to take that into account from the moment you start thinking about the guy. I mean, obviously, you have the the actual damage to the skeletal system that you have to address as an orthopedist, but you have to understand the physiology that goes along with it. So there's hemorrhage, there's pain and shock response. If the guy was sitting out in his car for a long time, he might be hypothermic. There's fat emboli issues, pulmonary issues that go along with multiple. Does he have another long bone besides that one, or just
That's it, but it's his
segmental?
talus is,
So a segmental injury, and then the talus, right?
his talus body is somewhere sitting not where it should be.
Yeah, so talus
And it's
should-
open, and
right.
it's a segmental
and so,
tibia.
And
What
then
do you want to do?
infection issues.
The clock is ticking. What do you
Wash them
wanna do?
out, reduce his talus, and then reassess intraoperatively and have a conversation with anesthesia about whether you can span his fix his tibia versus intermedullary nail.
Okay. Ken, any thoughts?
Yeah, that talus is a real pain at nighttime, and you see it, you don't have a mortise really to put anything into. It looks like the medial malleus broke too, which will help us some. And I'm just staring at that fibula. There's a lot of devascularized bone too. So one thing we see, because we do share call, it's not always a trauma guy on call, is the aggressiveness of, we can take care of lost bone, but devitalized dead bone, we can't. It's a battle, right, long term. So get a great aggressive debridement on everything, and I would open and reduce the talus. A lot of times,
Would you work through the open wound? I mean, it's an open talus. Would you
I would
first
work
try
through, I
to-
can see on that picture there, looks like your lateral side will take you home to the lateral approach on the talus. The other thing I'm looking at is that fibula. I would, after I debride that open wound there, looks like there's an open wound right next to the devitalized piece. I would strongly consider just putting an intramedullary rod up there to give me some stability and
You're talking the
recreate it.
fibula now.
Yeah, the fibula. Recreate the mortise. I would not tackle that nail that night. I would get the talus reduced. The problem with that talus reduction, if I'm reading this right, it looks like the dome's split in half. And so that can, even after you get it reduced, be slopping back and forth on you. So I'll do something to hold it in place, assuming it's not like grossly contaminated. If it's a standard wound, I've even occasionally will fix it. But at the minimum, I would get like buried K-wires in it to hold it, and then get a CAT scan to better plan step 2. On
Okay.
the talus, but I don't want to leave that talus unaddressed.
Bill, what was your thoughts? And this is your case.
Well, this obviously was a high-energy, open issue. I agree. When you see a talus outside of the ankle mortise, that makes for a difficult night. That's one of the things you think about. I want to emphasize what Susan said about clearing patients for the operating room. When residents come to me and say, Dr. So-and-so cleared him for the OR, I said, I'm the one who clears him for the OR. That's who does it. You have to look at everything yourself. You've got to be the captain of the ship. I've been burnt many times over the years, and the thing you owe the patient the most is to pay attention to detail. And if you don't think they're ready, they're not ready. The priority here is the guy's got a head injury. He's got a little bit of hypotension off and on. They're resuscitating him, but you've got to deal with him right now. One of the things that we're studying right now is acute kidney injury. We've not paid a lot of attention to that as we go along, but these long bouts of hypotension are really creating kidney injuries that don't reverse. And unless you're looking for them, you don't realize it. And we've looked at our past year and see lots of opportunity to pay attention to that detail as well. And we've been able to reverse a lot of the acute kidney injury that we're measuring. So I think that may turn into another parameter that guides us as we go along. Obviously, getting the talus back in, thoroughly debriding that, and I agree with Dr. Graf. I'm worried about vascularity distally. We don't mention IQ very much. This gentleman ran into an abutment to stop his car because his brakes failed. And I said, did you try using the emergency brake? He said, well, that hasn't been working for years. So, having patients' cooperation later is a big deal, and this is a bad injury for a guy that doesn't have very much wherewithal. So yeah, the priority is get the talus reduced, and try to fix that as best you can or temporize it. And then certainly making sure that the debridement is as thorough as possible. I agree with Susan, it's a debridement. Dilution comes with that, but the debridement's the most important part. And I'm old-fashioned, still use forceps, scissors, scalpel, whatever you need. You can't declare it sterile when you're done, but you need to get very, very close. That should be your goal every time. Then, once you've accomplished that, you have to start thinking about the rest of the tibia. When I think about that, the things that enter into my mind are intramedullary instrumentation, head injury, and/or potential chest injury. In my time, I've seen lots of people have a very nice-looking chest x-ray when they hit the door, and then 6-8 hours later, it starts snowing in there with a repeat. So you've got to be thinking about that all the time. You think about the mechanism of injury. Did the airbags go off? You want to know, did his chest, was it protected by the airbag, or did he hit the steering wheel? Those are all things you have to think about as you choose the next steps.
So Bill, this looks like it got in and it's pinned with a couple of wires, one across the neck, one across the plafond. It looks good. It looks good. Looks like there's an X fix on it as well. So this looks like how it's parked, I think, the first night with an X fix, talus reduced. You happy? Happy with that? Everybody happy?
Yeah, for considering we spent time on debridement, we wanted to get him, get the talus put back together and try to stabilize the rest of the fractures in reasonable position and get him out of that room quickly because he was a bit hypotensive, and I was worried about that, and the head injury.
Okay. Next steps? Next steps. Susan, next steps.
Okay, so you have your talus well reduced, but I think it, and we know now that probably just a simple talus doesn't necessarily need to go to the OR in the middle of the night like we used to think. But it's obviously in the best interest to get not only the long bone stabilized definitively, but the talus itself stabilized so it doesn't displace more and so forth.
Would you CT it at this point?
Oh, absolutely, yeah. We had one almost exactly like this except no tibia fracture, and the guy was healthy because it was his only isolated injury, but he extruded his talus 100% out through the medial side. It was stuck behind posterior tib, and it mowed a poke hole through the skin, so it was open, so we went to the OR with that, and because of the extrusion, obviously. We were able to make a lateral incision, clean out the debris, and pull it back over towards us. Then we'd had good skin to work through, and it could close up, you know? And so what we did was we put 2 cannulated screws across it and decided that that would be a provisional fix with an external fixer in place, and then went and got a CAT scan afterwards. And if we didn't like the 2 cannulated screws, we would have changed it, but we were pretty happy with it.
Always save the extruded talus body, even if it's
Yes.
literally has no soft tissue attached.
Yes, 100%.
Okay.
Sitting
Everybody
on the
agree?
stretcher,
Panelists
sitting
agree
on the
about that.
stretcher next to them.
Brought in a bag from the scene. Everybody going to save that talar body, or even the entire talus. Is that a safe statement? Do I hear?
That's safe
I hear
unless there's
nodding
like-
in agreement.
Yeah,
of
if
it.
there's manure on it or something, I probably wouldn't save it.
Okay, there you go.
If it, you know,
The
other than
manure-covered
manure or
talus doesn't get
grease
saved.
or
Like a
other
dog
than
carries
that.
it in or something like
the
that.
dog mouth. yeah.
All right. Okay. So you're going to get a CT scan, and would you proceed, I'm assuming a stable patient, to tibial nailing and fixation of that plafond? And maybe, as Ken suggested, a fibular nail. And we'll hold that thought because there's more to discuss about that topic coming up. Thoughts? Okay.
Well,
I'm
okay,
sorry.
I would say
Oh.
one thing about the fibula. It certainly depends on the quality of the skin and so on. But even if the skin's not too good, you might want to actually wait a little while and then do a plate on that fibula
That looks short.
because it's really short. And it's going to stay short with an intramedullary device, no matter how hard you try. So that's going to be a tough, and it's also might have a little rotational instability as well, which isn't ideally controlled with an intramedullary device. So even though those are great things to have in your toolbox, it might not be a good one for this guy.
I mean, you have a pilon, you have a talus, and you have like a segmental tibia all in the same patient. So, Bill, what were your thoughts?
Yeah, this was, the openness of this was very significant, and I was worried about skin preservation. The guy was unhealthy, a smoker, uses alcohol.
And old.
Old. And not responsible. I was very worried about everything. I was worried about preventing the baloney amputation on this guy, trying to preserve something for him. So my next thought was to try to stabilize this as best I could without creating more problems with distally based flaps.
Okay, so it looks like it's nailed, statically locked. It looks like it's got some lag screws across the joint. And it looks like you stayed with the wires for the talus fixation. You want to tell us about your thoughts on that?
I did. I looked at this under fluoro and with some plain x-rays in the operating room, and it was reduced nicely, and I was going to have to open the skin a bit more, and I'm trading off skin survival versus a reduction that seemed acceptable and stable, so I decided not to do that.
Okay. And I believe that was the final fixation, and the wires got removed at some point. Can you give us a little
Yes.
update on how the patient's doing at this point?
Yes, well, actually, he was in Thursday, and the talus is not doing well now.
AVN,
AVN, yep.
okay. But it's healed.
But it's healed.
Okay.
And we were able to preserve this length. I kept him weight-bearing longer, non-weight-bearing longer than I would normally. I was trying to preserve the mortise, and I had a feeling that the talus was going to undergo because we didn't really see a Hawkins sign develop.
So he's healed. He's got AVN, and at least that's what the assumption is. Are you limiting him in any way? Are you limiting his weight bearing, or you let him go and live his life and just watch it, or what? How do you take care of this guy now?
Yeah. Well, now he is weight bearing. He feels comfortable, but I could start to see the dome coming down. We have someone in our practice that's aggressive with talus replacements, and which are coming our way. I'm going to guess that this guy may be someone that is going to benefit from his potential intervention, but I'm letting him weight bear, and he's getting back to normal activities.
Ken, how about you for management of the talus that you know is going on to AVN?
Just tell them to hammer it, to walk on it, and sometimes give them a little ASO. But, you got to make a decision how it's going to be for them. There's nothing we can do now that I know. We can't do a osteochondral allograft or anything crazy. Just let them walk on it. And a lot of these guys burn themselves out, and then it just gets, you hope it gets stuck in like a plantar-grade position, and they can just kind of learn to live with it.
Any
I
other
think that's
thoughts?
better than the big talus replacements, at least what we've seen. We've only done a couple of them, but they're medium. I'd say. Not a big.
I don't know. The next step, if it gets really bad, you can just excise the talus and do a tibial calcaneal fusion. That creates a great leg length discrepancy, and I've done probably 4 in my lifetime, and I think they're more painful than just leaving the talus and letting them pound on it. That's what I found.
I did a person who had just a really disintegrated talus with a femoral neck allograft, and put a fusion nail up through the femoral neck allograft, and she healed.
That's becoming also sort of the salvage for total ankle issues as well. That's highly controversial, but yeah, that's a yeah.
I mean,
Yeah.
N of 1.
Yeah. Ken, this is your case? Do you want to
yeah.
walk us through this one?
Yes,
Remember
this is a guy, it's a while back, 40-year-old diabetic, morbidly obese male, sent to us from an outside hospital. This is the X-Fix. They actually called and said, this is the best we can get him.
So this is how it got sent to you?
Right.
Okay.
So this is how it got
Was
sent.
it Christmas Eve?
Yeah, yeah, it's probably New Year's or something, yeah. So you can see the kind of shard fragments of bone posterior medially. They're actually, one of them communicates down by the medial calcaneus. Technically closed, but by the time it made it to us, there was a pretty good size eschar right where the distal fragment is.
Okay.
And I'm sorry, he had also had that side was weaker from an ipsilateral stroke.
It's the CAT scan.
So, yeah, just
I
the
think
CAT scans.
Okay. It looks like there's not a, is there a P-line component? I don't think so.
So there was no P-line component.
Okay, it's just a really bad
And
shaft.
Yep, and the only fibula fracture was up there proximal.
Okay, all right.
And you can see the bone health on a 40-year-old should look a little stouter than that. He's pretty osteopenic.
Did you lose any bone at the debridement? Do you know?
We lost see that shard down there?
Yeah, yeah.
That was lost to debridement.
Okay,
The other piece had a posterior attachment to it, so we just kind of kicked it out of the way while we tried to address the one 2-millimeter piece of bone that would actually give us a length read.
your problem is you had length, but it was an incredibly low cross-sectional area, right? It was like
Right.
tip to tip, sort of?
Tip to tip, yeah.
Tip to tip, which always creates, a whole sort of bunch of interesting problems, which you're, going to tell us how to solve here. But, that tip to tip problem is, I think a real challenge. Can you create stability? Is it a segmental defect? Do you have to stage, a mascal layer or whatever?
It's a battle. And then the other thing doesn't show up well, obviously, because you don't see the soft tissue, but that proximal piece is stuck. That's why the guys couldn't get it. It wasn't that they were...
Or it was impaled
Yeah.
in the tissue?
Yeah. They weren't weaklings or anything. It was a Chinese finger trap on them back and forth.
Okay. So why don't you walk us through your thought process for this, Ken?
So we could get a lateral read. You can't see it's a double density. The posterior medial piece is pushed back behind the tibia. We get one read on that lateral cortex. And hadn't really done this before, to be honest. Try to avoid it, because if you have a complication with this surgery, I think you're going to be a little bit pissed off at yourself, right? Because now you got a plate inside the bone, but we just couldn't hold it. So we put an endosteal mini fragment plate on to hold it, and then a blocking screw just to help kind of align the rest of the tibia with the amount of bone defect.
And so this was all sort of at this moment's plan to have the endosteal plate. And I could see you be a little concerned about the nail catching it, the reamer catching it, or all sorts of things. But, it looks great.
The only reason we worry about that is because it's just going through space there, because the other piece is like hidden behind the back of the tibia.
Okay. What was the thinking, though, is to manage the rest of that defect at this point? What was your thought about the rest of the defect?
So the piece had the piece that had no vascularity to it was removed, and then we had left over a pretty good chunk of bone with not much, but a little wafer of tissue on it. So once we went ahead and pretended that didn't exist, proceeded with the rod. And the one thing I'll say about rods, and you guys are probably all aware of this, but you get that advantage of an autograft, right? That's the big advantage of a rod, especially in someone with a bone defect. So we thought that would be advantageous, and actually he delivered a ton of bone to us.
So
with
the
the reamings.
sequence of that, so capturing that, so was it reamed when you were open, or did you close it, then ream it and put the nail down to contain the reaming?
With
How
it
did you
open.
manage that?
With it open, and then we contained it, and actually had a bucket to put some in to put it back in.
Okay,
So
so
it
you were
kept a
reaming it,
sterile,
you were catching
container.
all the stuff that
Right.
was coming down.
Right.
Did you throw a little Vanco in that?
I did not.
Okay, just curious. So you
I did
contained it, and then at closure, you packed it all around the nail.
Right.
Correct?
Right.
Okay. Thoughts, anybody, panelists, thoughts on that? Susan, ever do an endosteal plate like that?
I've never done.
I have not, I have not. I mean, it looks great. I'd be also concerned if, it goes south. But, Bill, thoughts?
No, I've never done this. this thing says to me, no plate, no anterior tibial plate, no medial tibial plate. Diabetics and distal tibial plates don't mix.
Well, he didn't. He never touched the skin to put that plate on. He never made an approach.
No,
I mean,
not
seriously,
not
he
that
didn't.
plate.
I mean,
The endosteal plate's
Yeah,
fine.
yeah.
I mean, a definitive,
it's the ultimate, no approach technique. You do it
yeah.
through the inside of the bone.
I think it's really good that you put a blocking screw in there. This patient's going to have really poor quality metaphyseal bone, so you can't really count on the nail and its interlocks, maintaining its own place in time and space. So even if you don't need the blocking screw for the reduction, quote unquote, I think you need it to maintain your alignment down the road.
Yeah, I agree. So we do that a lot. I'm sure you do too. Even though you have it anatomic, you just fill up and make a canal down in the metaphysis wherever the nail is, just to give you a little extra support.
So what are you using? Are you using one of the locking screws? Are you using, a temporary locking screw drill bit? Or what are you actually using for your blocking screws?
I use a temporary because I find if I use a screw and I messed it up, and I'm kind of mad at myself. So I just change it over to a screw after I'm all locked up.
So you're using a wire or a drill bit?
No, that's a 5, the hell is it, 4-3 drill bit, whatever the heck it is.
Okay, so it's the same drill bit you drill the locks with. You put it across,
right.
leave it,
Right.
nail it, and then make a decision after that whether or not you're going to leave it or you're going to swap it for a screw.
Right.
Okay,
And by then, we're all locked up and happy with our alignment.
okay. Comments from anybody about that? Blocking screws, how many people here have used blocking screws as an aid to intramedullary nailing? I mean, it's a real help. It really is a help if you know how to use them, particularly when you're working in the metaphyseal regions.
I have absolutely used guide wires or drill bits to create some of the initial block and make sure it was how I liked it, but I almost always fill it with something at the end because I've had things drift early on in my career when I took the blocking drill bit out, and then things have drifted.
So you routinely swap it?
I do.
Yeah.
Yes.
Okay.
Yeah, I always swap it. If you get your drill bit right, you might as well take the advantage of the screw. You already caused the soft tissue injury for the drill bits.
I usually just use interlocks, from the same track.
Yeah, right. And it looks like that bone from the reaming really did very nicely to fill that gap. Patient do okay?
Yeah, he did surprisingly well. You're holding your breath a little bit because underneath all that crap, you got a little plate inside your canal. So.
Did the patient ask, what is that? Like, what is that? That's there because it has to be there.
The stroke made him a little bit hard to understand, but his mother asked it quite a bit, yeah.
Right. Excellent. Okay, nice case.
Can I add one little
Yeah.
thought to the audience? He has a CVA, and I think there's some people that would say, oh, well, do you really have to fix it? Can we just put it in a cast? I see that kind of response all the time with paraplegics and quads and stuff like that. And I don't know what the other panelists think, but I'm pretty aggressive about fixing these things. I mean, let's pretend it's not open, all right? Pretend it's not even high energy. Let's pretend they just got their foot caught underneath their wheelchair. But the amount of patients that go on to have soft tissue compromise from spikes of bone and stuff like that because they're just flopping around forever, I've seen so much of that, and it's really a devastating complication for them. So I've been really aggressive in fixing patients, even if they're not ambulators, and they do much better.
Yeah, I can totally echo that sentiment, yeah. Okay, Ken, this is another short case. Why don't you, I think you're trying to make the point of the utility of fibular fixation as an adjunct. Want to talk us through this?
Yeah, this is a 64-year-old guy, type 2 open tibia with a segmental fibula fracture and a compartment syndrome. And the only point of this, how many people would put a fibular nail in this at the time of their definitive fixation? Or so nobody. That's good. Oh, Masher, yeah. So
I think it would depend on how much. If I really thought it was, I mean, that's a comminuted tibia, so there's no length read off that tibia very easily. I mean, not
Right.
there's a better length read off the fibula, and it's going to certainly aid in creating alignment.
You already have a fasciotomy incision.
Right,
You
that was the
basically
thing.
just put your
Just
finger
like
in there and
staring
hold
at
it
it, we have
and
some
put it
like free read on it. So I do err on the side of using it, but like you said, only if you feel like you need it for A, stability, or B, alignment, right? 'Cause you can see there's quite a bit of devascularized bone on that x-ray that needs to come out.
What are you guys
So-
using for that?
For what?
For the fibular,
I use the elastic rods.
like?
What are they
like
called?
central
You know,
elastic stuff?
yeah, for like you use them on kids' femurs and
Yeah.
stuff.
So Ken, way at the top of that image is another fibula fracture.
Right.
Are you going to go for that too, you tough fibular nailer you?
All right,
Are you going to
for
go
it.
the whole way up?
Yeah, we go for it, because we're trying
Okay.
to get
All right,
the
excellent.
column established, so
All right,
I don't know if we succeeded or not.
all right, let's just see. It looks like
Oh, yeah, good.
you took that bad boy all the way up. All right, so this is, what's the diameter of that, would you say?
So I'll tell you that, like, when you first, like, try to do it, you put in too big a one, almost always. So I think there was 2.5, I think it was.
Okay,
Almost always, though, your first choice is too big. We've tried 18 different ways to measure the canal, and it's like,
ever had to take one out
Still a
for
guess.
issues, Ken?
I just had one, yeah, but it was for a guy that had a bad soft tissue envelopes. He got one for a peel. And it got a little prominent on him. Some guys leave them long with the preparation of taking them out. I do not. I try to bury them under that bone, because otherwise I figure why you're putting it in.
So your plan is never to come back?
No, the plan's
Yeah.
never to take that.
Yeah. Anybody have thoughts? Very nice. Yeah, I think it can be a real asset in certain cases. Very nice. Okay. This is one of my cases, 77-year-old woman, low energy fall, total knee replacement 7 years ago, stable knee, no problems with it prior to the fall. What's the general approach to that? I know that sounds like a pretty basic question, but Susan, periprosthetic fracture above the knee, stable knee segment, reasonable, you can make an argument how big that segment is, depending on your thoughts, but what's your generalized approach when you see that?
Yep, so I always have a conversation with my joint partners about, their best assessment as to the stability of the prosthesis itself. I've actually had, I really like, I know we don't mention companies, but there's a particular periprosthetic system out there that's outstanding, and I've even accomplished success with some prostheses that the joints guys said there's too much fracture into that segment, it's not going to be stable, and we've been able to heal them to solid union.
How about general philosophy of nail versus plate? Do you have a feeling on that topic?
That, I would plate that.
Would you ever nail it?
Yeah, if it was higher up maybe a little bit, and a little bit less comminuted around the prosthesis.
Okay.
And you have to make sure your prosthesis has an open box.
Sure, yeah, assuming that it's got an access point. Bill, thoughts on that?
Sure. One of the things I'm always amazed with, we get a CAT scan, and it looks like the segment of bone that's still attached to the femoral component is too small, but somehow you're always able to get fixation through it. I try not to abandon these things, and changing this to a distal femoral replacement with a hinged knee is a lot of surgery for this patient, and it's an extremely expensive device. You could spend $28,000, $30,000 for that operation just from the distal femoral replacement. So I try my best to, in this case, if I can plate it, I prefer plating it. The retrograde nails work okay, but I think I have a better chance of salvaging this if I can get several locking screws in that distal piece, and it gives us, I think, more stability than I can ever achieve with a retrograde nail.
Are you willing to shorten and compress it a little bit? Are you willing to accept a little shortening to get a little compression?
Yes, absolutely, and I don't mind operating on the other shoe.
Ken, thoughts?
Yeah.
Oh, yeah, I would plate it also, especially that one CAT scan showing the little defect. I think you could nail it. The poly looks pretty big. So I struggle getting the poly out a lot of times when you're nailing them. But the other thing on the plates, we're looking at these because we have a pretty aggressive tumor service and we're going to start randomizing. But our retrospective stuff, they're not, you think you're going to get them walking right away with that hinged knee, but we see them consistently on rounds. It's not much different than when we fix them as far as their ambulatory status. And we're not seeing a big difference in the, in the morbidity and mortality right now. So I would fix it.
Okay.
Yeah, and the one thing about using the plate system as opposed to a retrograde nail is that you do not have to reopen your surgical incision for your total knee. And the joints guys like that. They like not to have that knee, it's not really violated,
Yeah.
You're just barely seeing the edge of the metal, barely, And so you're kind of keeping their parts and your parts separate. It's better that way.
So this is actually what's above there. I was not being forthcoming, exactly.
As always, right?
Yeah, I know. I see you picked it up. That was good. Yeah. Okay. Does it change your plan? Change your plan? How does it change your plan? You wanted to
You
nail
wanted
it.
to nail it.
Okay, good. But now no go? Okay, hold that thought. Hold that thought. You wild guy up there. The platers in the group, would it change your plan?
Longer plate,
Longer
you got to
plate.
span
Would
the
you take it
prostate.
all the way up? And how would you get fixation in that proximal piece around the hip stem? Bill?
Eyelet and cable and unicortical locking screws help provide stability and avoid a stress riser.
Okay, so everybody would take the plate up around the hip. You wouldn't stop it in the diaphysis. I mean, there's a fair bit of diaphysis below the hip stem, and it looks like pretty good cortices. So you wouldn't stop it short of that if you're going to plate it. Do we have any good, guidelines that tell us that that's bad?
No.
We talk about it, but I don't think we have clear biomechanical guidelines to tell us how to manage this problem.
Yeah, there's not.
No.
There's not.
And it's the coming epidemic.
The other issue here is BMI. And you ain't had a headache until you've had one of these lateral plates pull out. And you have to go back and revise it. That's why I would have a tendency to go to the long plate, make sure you've got good purchase distally, and you avoid the potential problem of periprosthetic fracture. There's an epidemic of that going on now. When I'm fixing an intertrochanteric hip fracture, I'm in an elderly person. I'm almost always going to a long rather than a short device because they fall again and they pop right under that, and it creates a bigger problem for them in the long haul.
Would you let them weight bear with a long plate, as you described? Or would you?
I wouldn't let them weight bear right away, no.
Okay, so you'd
No, they'd be transfer bed to chair.
okay.
BMI directs me which way we're going with that. And as soon as I see some healing, we could start 25% weight bearing. In this population, they're going to be 100% no matter what you do.
Okay.
And so it's a very difficult thing, a limited weight bearing. So I wait till I see something. I try to make a move around, and some weight's going to get on that, but you want to give them an opportunity to get some significant healing before you do
Get the
it.
fatigue life turned down a little bit. What are you going to do, Matt? Plate all the way up similarly? Okay. Okay, so this was actually my partner's case, and he's put this in a little distal femoral traction, and there's a retrograde nail. That's I believe that's a synthase retrograde nail with an end cap locking on that little blade plate there. And there you see the lateral view. And this was planned then, stop it short and then protect the entire bone with a plate. So a nail plate combination. And this is a variable angle locking plate. And there you see the construct. And his argument, we had this long discussion about this at our conference, and he said, well, I can weight bear this now. Now, I don't know if the biomechanics for that are particularly any more defined than the biomechanics without that. So this whole concept of nails and plates in long bones and in prostheses is going to be, I think, a very interesting ongoing topic that we have very few guidelines for at this point. This went on and did well, but it's an interesting concept. The idea being that the nail controls translation and angulation, and the plate controls rotation and length. As you notice, he didn't lock the nail proximally because the plate was managing that control of fragments.
Did he weight bear them fully?
Well, he said weight bearing is tolerated. You know, I don't, you know. Yeah, well, if you can do that. Yeah, go ahead. Okay. A 10. Yeah. 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 Yeah, yeah, basically with the yeah.
As long as you let the weight bear automatically do this, it's all work to do this. If I would plate it, I would let a weight bear. If I nail it, I let a weight bear. This construct.
Thoughts from the audience? Any other thoughts? Okay.
The hard part is, like, do they weight bear? That's the hard part for me. When I see them, I tell, there's some patients with this fracture, they're old enough and thin enough, we say, go ahead and, you need to get out of bed, put some weight on it. And the other ones, like the DFRs that we see, they're just not putting weight on it because it hurts too much. So I don't know how much she gains.
So your theory is they put weight on it based on their pain?
I think that's the way they do it.
That's just what happens in the real world.
In the real world, yeah.
I think the only other thing you have to take into account too is time on the table,
Yeah,
because they're
Yeah.
old
yeah.
and the clock is ticking.
And this took some time.
Their joints open.
This definitely took some time. Agreed. Okay. And,
Looks good though.
okay, this is my case. This was a recruited scholarship Penn State linebacker who a year prior to this had a bone patella bone ACL reconstruction and was actually at one of the postseason bowl games and sustained a patella fracture in practice. Locally had a repair with 3.5 screws, and there's a fiber wire tension band through that you can't see. 2 weeks later, comes back after the bowl game, and follow-up x-rays revealed this, which wasn't there at the post-surgery x-rays, that gap in the patella. So, what do we do with this scholarship athlete? Bill?
This is, the bowl game's over?
Yes, the bowl game's over.
Bowl game's over. He's a sophomore?
Yeah.
Yeah. I redo it.
You'd what?
I'd redo it.
Redo it. How would you redo it?
I'm worried about the gap there.
So you wouldn't accept this?
Well, here's a guy who, if he's a linebacker at Penn State, he's probably going to be a professional football player. 'Cause
Well, that's what
where
he
they
wants
come
to be.
from.
So does his whole family.
That's where it comes from. I'm worried about the gap that might fill in. He's a young, healthy guy, but if he can't be ready for the first game,
So it's January, right?
yeah, January. I think I want to be aggressive with this, and I would try to get a better reduction.
Okay, do you want to speak to technique? I mean, would you, same kind of technique? Would you use different
yeah.
screws?
I love your technique. I might, I use the fiber wire, figure eight fiber wire. I think it works very, very well. You have to make sure that your screws are countersunk very well. But I would just repeat what you did and protect him longer.
Okay, I didn't do this, but anyway, I go with bigger screws instead of those 3.5s. But Ken?
Yeah, I do the same thing, treat it. Well, I'm assuming you said they have x-rays showing it was healed
Yes,
before all
yes.
this. So this is a new injury?
Well, it's happened sometime in the 2 weeks post-surgery.
Oh,
Not healed, just better reduced.
I
No,
get
so this is 2 weeks after the surgery. At
2
the
weeks
time of the
after, I
surgery,
get you.
the patella was compressed, at least looked like it on the post.
Yeah.
This is his picture now when he comes back to the area. They were in Phoenix. He came back to the area now,
I get you.
and this is the follow-up x-rays in the office.
Yeah, I would just treat it like a 9. I think the 3.5s are too small. I usually use 4s, but depends how big the guy is. too.
He's
I'm
big.
assuming
He's a linebacker. He's a
linebacker's
Penn
beast
State
of a
linebacker.
guy, so-
He's huge.
Yeah, so
We
you gotta
are-
use whatever
Huge.
he needs for his patella to
He's huge.
compress it. And you gotta
Yeah.
get it anatomic, and I would redo it.
Okay. Susan?
I would first get a CAT scan, because I want to make sure that the reduction is as good as it looks, and just make sure that there wasn't a step-off that needed everything taken apart.
Okay.
If it didn't need to be taken apart, I don't really know that 3.5 to 4.0, which is what I usually use, is going to make that much of a difference. It's not like he's walking down on those screws.
Okay.
He needs to be more compliant, and you have to have a heart-to-heart with him if there was any component of non-compliance, or if you let him go too, or the person let him go too soon, then you gotta.
Well, the trainers got after him.
Yeah,
You know how that goes.
yeah. Well, and personally, have never used the fiber wire tension band technique, so if there was any concern, and I don't know this is the case or not, that those can cut if your screws are too long. You gotta make sure your screw
Okay.
wasn't too long at the end there, you know, your screw should
So you're
end.
concerned that the fiber wire may have torn over the broken, or the end of the screw because it wasn't recessed in bone?
Correct.
Okay.
So you always
Does everybody
gotta be-
understand what she's talking about there? If you make your screws too long, whatever the tension band material is, it comes directly over top of the screw, and it can create a tremendous friction and prone to breakage.
And that's true for a wire too, for that matter.
Yeah,
And-
true.
Wires
and-
fail too.
And,
Yeah.
and the thing is, you can't, because of the way that the patella is shaped, and it's got that sloped, you know, kind of apex anterior surface, right? You can't look on the AP and say my screw is the right length, because if you're in the middle of the patella, you know what I'm saying? You're seeing that radiographic line on the AP that's not really where your screw is exiting the cortex.
So the way I actually take a tenaculum, the one that I've used to hold it,
Yeah.
and I actually use that
To turn the
as the
patella, right?
measurement. I use that as the measurement, because
okay,
that's
okay.
bone on bone, and that's how I measure my screw length, that's where the tenaculum was
That's a
sitting.
good idea.
So,
Hey,
Okay.
Spence, his ligament exam's normal? I assume
his
that's-
ACL
that-
ligament exam?
PCL.
Oh, it's PCL. I'm not sure I can comment on that,
Okay.
actually. I get your point, though. Okay, so we decided to use a little different technique. So we redid the whole thing. These are 4-5 lag screws, over-drilled, lag by technique. And then we used a mesh plate, which is a technique that's been described now for a couple years, came out of HSS. But this is the mesh plate, synthase mesh plate that's cut in a certain way too. And you actually can run a Krakow suture through the patellar tendon and then tie it to the plate as well. With the idea you can be very, very aggressive with postoperative rehabilitation. So I'm just showing you this, and that's the reference from 2015, and that's the technique of, is that projecting okay?
Yeah,
Okay.
that's good.
Okay. So I'm just showing you this as something to think about in a revision patella. It actually works, and the problem is, is it going to be problematic from a soft tissue standpoint? And I think that's the concern with it because it's a little higher profile.
Yeah, I think it's a great device. One of my partners started doing it. I wasn't a real big fan, but if you have a patella in 3 pieces, I think this is a better alternative. It really allows you to gain purchase in multiple directions and provide good stability. And I think it's going to be very useful. I need to learn how to use it better going forward, but I think it is an advance in what we're doing now.
I'm sure in a young person, it's better than a partial patelectomy, which really is a lousy operation for a young person.
Yeah, and we've used it for elderly people too, just because of the problem of comminution. Anybody have any experience with it? Good. Thumbs up. You got a thumbs up from Sakib. Okay, very good.
It's been good. We had one lady, the first one I had to take out was just recent. The only thing that gets your nerves a little bit is that stitch that you have from the tendon into the plate, but it's always healed by then. The rest of the people haven't had, I bet he won't need it taken out. He's a big beast of a guy.
Yeah, he is. He hasn't returned to play, though. I think, honestly, his quad atrophy from the combination of the ACL, which I don't think he ever got all the way back, and this, he's just not able to get back to the numbers to start. So this could be a career-ending event for him from the standpoint of NFL. So, okay, this is going to be our last case. So this is a 62-year-old woman who presented with these x-rays to the total joint service. with a pretty badly arthritic right knee. So she had a femur fracture at age 16, treated in traction, healed. You can see the deformity. Now she's got right knee pain, and she's come to the total joint service requesting a knee replacement. I know this isn't exactly trauma, but just bear with me. Bear with me. Thoughts? Do the total knee, forget the deformity, fix the deformity, do the total knee, tell her to go out and ride her horse again. Bill?
I like fixing deformities. Certainly there are computer-assisted devices that can give you a normal biomechanical axis with this malunion. I do both these operations. If this comes into my office, I tell them I want to fix that femoral shaft first and let you walk on it and see if it's bad enough to have a knee replacement.
So you're hypothesizing that perhaps deformity correction may give her less pain in the knee.
May buy time for her natural knee.
Okay, I understand. Susan, thoughts on this? This is something that,
Well, I'm sure you had them, but we don't have them, like dedicated knee films, obviously, probably maybe even a CAT scan of the knee.
Okay.
Because it looks like her condyles are a little flat, like, like horizontal.
yeah.
So I'm wondering if she has either acquired deformity over the years, or something that.
Oh, you mean like a secondary deformity or just?
Yeah, like
okay.
yeah, something like that. And she certainly looks like she may have some patellofemoral disease too. So, then the question becomes, okay, what if she was 72 or maybe even 82? How aggressive do you get with that femur?
Sure.
As opposed to just trying to fix what she describes as her problem, it's hard to know.
But let's say she's 62, so she's still pretty young for
She's
a total
young.
knee. I mean, what is the life expectancy of that total knee done in without correcting that deformity? I mean, she's got a significant valgus. If we draw an axis line, it falls way outside of her knee. It falls outside. It's almost through the fibular head.
Yeah, it would be hard to correct this to a normal biomechanical axis. You could get closer, but at 62, the implant would be in grave danger of failing early. And
So if you were taking your boards and you were a joint surgeon, it would be deformity correction prior to, or nobody probably do it concurrently, maybe, I don't know. Prior to?
yeah, that's what I would do. There are some people that try to do concomitant work like this. I think that's too much stress. There's no reason to stress someone that much.
On
It's
who,
like-
the surgeon or the patient?
Well, the patient. 'Cause
Okay.
I have been vehemently opposed to bilateral total knees for decades, and we recently got smart about not doing them. So I would do them. I'd do this one at a time.
Okay, so I did not see the patient at this point. I saw the patient at this point, when she did fall off her horse. And then I sort of got the whole story. So now the question becomes,
Ouch.
yes. So what do you do here? Do you fix the fracture? How do you fix it? Do you do the deformity and fix the fracture?
Yeah.
What do you think?
Now it's
Distinguished
easier.
panel.
Now it's easier to convince her that she should have something done about her femur bone,
Okay, yeah, so she needs surgery anyway, right? Yeah, she
Yeah.
definitely needs to go to
I
the
mean,
OR.
seriously, what if she had developed a non-union from your heroic efforts at straightening her, And then she was dealing with that. Now she's got good reason to have femur work done,
Yeah.
Oh, so you feel, this is no longer elective, so you feel a little less, bound by, I see.
That's why I
get
went
it.
into
Okay,
trauma,
all right.
because I don't have to have that guilt about why did I decide to operate
right.
on this guy in the first place.
First question, fix the fracture independently of the deformity or do it all at once? Bill?
Do it all at once.
Yeah,
Ken.
all at once.
Susan?
All at once.
Okay, good. How?
Boom.
How are we going to do this? How would you do this?
I've had the opportunity to fix a femur fracture on a freedom fighter back from when Russia invaded Afghanistan. His group then turned into the Taliban. But working on a deformity like this, you have to do a lot of preoperative planning, look at alignment, look at the cortical bone that's involved around the fracture site. and plan on taking it down, remodularizing the pieces of femur, and make cuts that will allow them to align properly. There are times when you're going to have to sacrifice length, and you have to consider doing that. Then go ahead and I would use an antegrade technique with an IM nail then to get it back. I would prefer doing that than trying to use a laterally based plate, because I believe that the stimulation from the intramedullary reaming really helps this go on to healing. Whereas with a laterally based plate, if you just make osteotomies, line things up, and plate it, the ends of the bone that are a little less vascular now than they would be if there was a regular marrow cavity won't become part of the biologic field.
So you think the nail's going to help that quite a bit?
I do.
Yeah, yeah. Ken, thoughts?
Yeah, no, I agree with Bill. I would take down, the only thing I would probably do, I'm not sure I could control that distal piece with an antegrade nail. I'd probably do a retrograde nail. I think the joints guys, once you get them straight, can work around your nails with those, the computers when she needs her joint down the road. A lot of times, if you get her straight, a lot of times they can delay that joint for a long time, though, because she's really valgus on that standing film. So once you get her straight in her mechanical alignment, I think she'll probably avoid the total knee for a while.
Susan?
And she's corrected some of her flat condyle because her distal piece is in a little extension. So maybe she would be all right. Yeah, I would go with the retrograde nail probably.
Okay. So I didn't think I could accomplish two things with the same implant. So what I did was treat the deformity with an antegrade nail, and then I treated the fracture with a laterally placed distal plate. And we actually, like you suggested, Bill, we actually opened up the ends, but then we actually cut it this way, and we actually got her an inch of length. We gained an inch of length that she lost by doing that, and then passed the guide wire past the nail, and then that's a couple interfrag screws, and then just went with a laterally based plate. And we didn't lock the nail distally because the plate was going to control rotation. And that's how she ended up, and that's her pre and post-op, and she actually is pretty darn happy. And at the moment, she's not looking for a knee, but who knows? So.
Super.
That's a great job.
Yeah, that's fine.
Thanks to you and the horse, huh?
Thanks. Any other questions? I think we're out of time. I want to thank my panelists. Thanks, everybody. Appreciate it. I think we have a break coming up, Saqib, is that right? Or